صباح الخير جميعا. I think we have to start. It is 9 o'clock now. And that's the time we have to start. Give me a great pleasure to introduce to you Dr. Mohammed Khair. He worked in Hamad Corporation and in Qatar hospital. And I think, he's going to talk to us about a thyroid disorder in a pregnancy. Welcome, Dr. Hamad. Thank you very much.
Assalamu alaikum wa rahmatullah. Good morning, everybody. Thank you very much for your nice introduction. And thank you, Dr. Wiam, for the invitation for this prestigious conference. Today, our talk will be about thyroid disorders in a pregnancy. I don't have no conflict of interest and no disclosures. Today, our journey will start with the normal physiology and pregnancy of the thyroid. We'll talk about hyperthyroidism in a pregnancy, thionides in a pregnancy. We'll also reach to the station of hypothyroidism in a pregnancy, then subclinical hypothyroidism and the pregnancy outcomes, and anti-TBO with euthyroidism. And this will end our journey for this lecture. We know that thyroid physiology and the pregnancy, it is the relation connected between the mother and the fetus and the placenta. So if there is some changes in the mother with the thyroid and the regulation of the thyroid to supply with the regulated amount of thyroid hormone for the fetus for the development, and the placenta, it is like the buffer to regulate and to prevent any oversupply or undersupply according to the need for the developing fetus. So usually normal adaptation during pregnancy will affect the thyroid binding globulin, the TSH. HCG has effect also during the pregnancy, T3 and T4 and iodine. So the changes during in the mother, thyroxine binding globulin, usually it will increase during the pregnancy because of the effect of the estrogen. It will induce the TBG production in the liver, also the TBG sialation, and this will decrease the clearance. And usually this will happen during the first trimester and plateau at around 20 weeks. The human chorionic gonadotropin, it is a common alpha subunit and unique beta subunit. Common alpha subunit homology to the TSH, but it is weaker on the TSH receptors, and that's why in the HCG is rising during pregnancy. It will induce the thyroid and the mother to produce T3 and T4, and this will also make negative feedback on the pituitary to decrease the TSH production. Then this will also change the hormone in the mother. What happened to the thyroxine and the triiodothyronine? Due to increase in the T4 and the T3 production, the total T3 and T3 and T4, because of the TBG is increasing. But what happened to the free T3 and the free T4? Usually it increases initially, then it will stabilize, but also according to the lab and according to the manufacturer and the way they are measured, sometimes there is no clear cutoff and during the pregnancy, but sometimes if we are using the equilibrium dialysis, it will show us there will be slight increase in the T3 and the T4. The iodine during pregnancy, the iodine also is increasing in the requirements because of the maternal T4 production. Because of the GFR during pregnancy is increasing, that's why the renal clearance will increase, and there will be effect to maintain the supply for the fetus and the developing fetus. But there is a problem if we have undersupply or oversupply. Undersupply will cause problem with the hypothyroidism. Oversupply can reach the fetus because the thyroid in the fetus is sensitive. This will cause hypothyroidism and can lead to goiter. That's why the WHO usually the limit between 250 microgram daily and the pregnancy and lactation, but the upper tolerable dose should be around 500. The ATA, they said the limit is around 150 of microgram of iodine daily, and most of the prenatal vitamins also contain this amount. The TSH is also very important because it depends also on the population-based trimester specific reference ranges for serum TSH. But if we don't have, the upper limit is like usually 4. We are considered as 4. Now we'll reach the fetus and the thyroid. Usually the follicles will be detected, or the thyroid follicles, around 10 weeks. From 18 to 20 weeks of gestation, the fetal pituitary thyroid axis is developing, and the fetus now is independent of the mother supply. We can see here that the T4, usually it is total T4 is detected in the blood, and it is coming from the mother, and then the axis will be developed to produce its own thyroid axis and also its own supply. But the thyroid hormone is very important from the beginning of the pregnancy for the neuronal development. If we look here, even in the start of the pregnancy, neuronal proliferation, neuronal migration, it needs the thyroid hormones. That's why if there is any problem, it will affect the neuronal development and can adversely affect the fetus. What is the effect of the placenta on this regulation? We know the fetus needs T4, but also to protect the fetus from oversupply from the mother, there is the deiodinases, and also it will protect from the T3. That's why usually we don't advise to supply the pregnant lady with triiodothyronine or the T3 supplements. And if she was already before the pregnancy, it should be on T4 or levothyroxine only. Now, our next station in the journey, it is hyperthyroidism and the pregnancy. Usually, the rate usually it is between 0.1 to 0.4% of all pregnancies. Usually symptoms overlap with the normal pregnancy. We know the mother is tired, feeling shortness of breath, and palpitations, and these symptoms also overlap with the symptoms of hyperthyroidism. So usually sometimes there will be delay. That's why we have to be very cautious when dealing with these ladies. Hyperthyroidism and the pregnancy outcomes, usually higher incidence of pregnancy-induced hypertension, fetal growth restriction. It will affect fetus with low birth weight and also increase the risk of preterm births. But the subclinical hyperthyroidism and the pregnancy, usually we can consider the pregnancy, it is subclinical hyperthyroidism state, as we discussed previously. That's why in some less likely to be complicated by hypertension, although some studies show there is increased risk of preeclampsia. Usually the pregnancy complications, the perinatal morbidity and mortality not increase, and also it showed there is even decrease in the spontaneous abortion. What are the causes of hyperthyroidism in a pregnancy? The most common cause is Graves' disease. We have to differentiate it from HCG-mediated hyperthyroidism, and also thyroiditis is a possible cause, toxic adenoma, and toxic multinodular goiter. Usually the HCG-mediated hyperthyroidism will be divided into two categories, like gestational transient causes and hyperemesis gravidarum. Usually the gestational transient hyperthyroidicosis due to the physiologic concentrations of the HCG, usually with the multiple pregnancies like the twins and triplet will be higher. That's why usually subclinical or mild, resolve when the HCG level fall, usually after the first trimester. Treatment is not usually needed. Hyperemesis gravidarum, although sometimes the hyperthyroidism can mimic the, due to Graves' disease, mimic also the symptoms of hyperemesis gravidarum, but it is due to higher HCG and estradiol, HCG more thyroid stimulating activity, but it is, there is nausea associated with nausea, vomiting, and the weight loss, more than 5% of weight loss, usually also resolve when HCG. Very rarely we need antithyroid treatment and need supportive treatment for the mother. Graves' disease, usually the goiter and ophthalmopathy, TRAB is positive. Ultrasound, neck, usually there will be increased blood flow, but this one should be like some experts in the radiologist to detect the blood flow, sometimes difficult to differentiate between normal and the increase or the decrease. And radionucleotide imaging is contraindicated during pregnancy. The treatment goal, we have to treat the patients to allow for mild hyperthyroidism because over-treatment or under-treatment will affect the fetus. If we are overly treating the fetus, the supply will decrease to the thyroid hormone and will enter like the hypothyroidism of the fetus and the goiter. And if we are under treatment, the T4 will be overly reach the fetal blood, and this will cause like suppression of the TSH from the fetus, pituitary, and will end up with central hypothyroidism. The therapeutic options are thionomides and the surgery, and usually the surgery is the optimally, if we need it, usually in the second trimester. Now, regarding the thionomides, this is the question, is always important. Should we start methimazole versus PTU? And there is studies like regarding the kinetics of the PTU versus the methimazole. It showed there is a similar placental transfer kinetics, and they have the same effect on the fetal thyroid. Then, is it safe to give methimazole or the PTU? Both of them, they have effect on the teratogenic effects, and will increase the teratogenicity, especially if we are using them in the first trimester during the embryogenesis and the development of the organs. It can cause guanal atresia, esophageal atresia, omphalocele, omphalomesenteric duct anomalies, aplasia cutis. Aplasia cutis, with there is like discontinuation of the skin of the scalp. But it is the higher risk of the birth defect compared to non-exposed. So there is a lot of studies showing that compared to the ladies who were not exposed to these medications, we have like the risk of congenital anomalies around 5%, but can increase to up to 9% if we are exposed to these medication, and especially higher in the methimazole, carbimazole compared to BTU. And the birth defect usually in the methimazole incidence of septal heart disease, the BTU will be less severe, and it can affect the ear and the urinary tract. That's why, if we diagnose the Graves' disease in pregnancy, usually in the first trimester, the PTU should be used. Methimazole after 16 weeks, or continue BTU if it's stable, but sometimes the problem with the BTU is the adverse effect on the liver of the mother. That's why we have to be cautious in this regard. Thionomides may be tapered and stopped during the third trimester, especially if there is a drop in the thyroid stimulating immunoglobulin. We know that the Graves' disease, sometimes it will be the activity will increase during the first trimester, it will decrease within the second and third trimester, and sometimes the activity of the disease itself will increase after delivery. And radioactive iodine is contraindicated, and the effect on the baby depends on which age of the gestational age. Usually, if we are exposed during the embryogenesis, the whole body will be exposed to radiation, but after the development of the thyroid, usually the thyroid of the fetus will be affected. And this topic is very important. We have few patients where we are struggling because it has to be evaluated by the legally religious issues, and if we need to terminate the pregnancy or not. So it should be very cautious. And usually if we are giving radioactive iodine, it depends on the countries and the regulation of the countries, but usually up to 6 months. I'm always stressing on my patients not to get a pregnancy and to be cautious, even using 2 types of contraception if she's taking radioactive iodine, especially in thyroid cancer cases. TRAB, or the TSH receptor antibodies, should be measured in all pregnant women with Graves' disease when diagnosed or in the first trimester. If positive, it should be repeated again in the 2nd to 26 because it can drop, and this will also affect our treatment. Usually, it also should be measured in all pregnant women with history of Graves' disease who were receiving definitive treatment before pregnancy, either radioactive iodine or the surgery. We know that the level will be dropping if we are giving her or definitive treatment, but also this is important to know that still the antibodies, because in autoimmune disease, the antibody also, it is there, and the mother is having iatrogenic hypothyroidism in replacement, but the antibodies can reach the fetus through the placenta and exert effect on the fetus and causing neonatal Graves' disease. And if the TRAB level disappears in the 3rd trimester, antithyroid drugs should be tapered and even stopped. Now, the next station in our journey will be hypothyroidism and the pregnancy. Hypothyroidism also can be overt or subclinical. The overt is associated with high TSH, with low T4, with symptoms could be also the same as in hyperthyroidism, attributed to pregnancy, weight gain, sleepiness, constipation, and also these related to pregnancy itself. The TSH measurement in symptomatic and the screening programs, though we need in any screening program to see the benefit of the screening, the cost effectiveness, and if it will help to decrease the complications of these things. Usually the screening and living in any area with moderate to severe iodine insufficiency, if there is symptoms, family or personal history. So this is not a general screening program, only for the case detection in high-risk patients, like in type 1 diabetes, age, if there is goiter, if there is use of amiodarone or any medication that affect. Usually the screening will start with TSH, and if we are, can be repeated also the TSH to confirm the reading. If we have high TSH, we can measure the free T4, and if the TSH is borderline between 2.5 to 4, we can measure also the anti-TBO. Usually the overt hypothyroidism is not common during a pregnancy. It is the same prevalence as in the hypothyroidism, although we know that the overt hypothyroidism is much prevalent than the hyperthyroidism. But the reason for this, and most of them, they have anovulatory cycles, so they are having infertility or difficulty to get pregnant, and the risk of first trimester abortion will be high. But the treatment is important here because hypothyroidism and is associated with the preeclampsia, gestational hypertension, placental abruption, preterm delivery, low birth weight, increased rate of cesarean section, postpartum hemorrhage, and also cognitive impairment in the child. Here, it is difficult to conduct any research to see if we have to treat or not to treat, because it's unethical not to treat patients with overt hyperthyroidism, but because of the benefit, we have to treat all those patients. While also the controversy is coming from the subclinical hypothyroidism, where the TSH is high but the normal T4. Also, it depends on the anti-TBO status. It is associated also with negative pregnancy outcomes and fetal outcomes, and the treatment outcomes also will be, there is a lot of controversy regarding the treatment. So regarding the premature delivery, increased risk of a premature delivery and risk increased with a higher the TSH. These studies showed there is unchanged even with the anti-TBO status. It depends also, the most important factor here is the TSH rather than the TBO status. And we know in the autoimmunity and the pregnancy outcomes, increased risk of miscarriages, higher risk with increasing TSH, the highest risk, especially in those with higher TSH, and the positive TBO antibodies, in contrast to the previous. Usually, subclinical hypothyroidism and preeclampsia, the same. It is higher risk with subclinical versus euthyroidism. No differences in isolated hypothyroxanemia. No differences even in the positive anti-TBO antibodies. It will affect also the baby, yes. The IQ is a few points less in the subclinical hypothyroidism compared to euthyroidism. And this is very important because it will give us like idea that how the thyroid hormone is needed during the brain development and very early in the development. And here we have like case cohort study within the Danish national birth cohort. They took like subcategory, and they showed that subclinical hypothyroidism and even overt hypothyroidism in mother were associated with increased risk of autistic spectrum disorders in children, and the low thyroid hormone also, it is also increased risk of ADHD in children. So this is very important. Now is the treatment. The controversy is the treatment. We know that the negative effect is there, but does the treatment will affect the outcome or not? There is some benefit and there is some no benefit. That's why there is controversy. So in the benefit, in the case finding versus screening, it showed there is benefit, especially if we have TBO antibodies. And a lot of studies showed the same thing, and also it can decrease the risk miscarriages and the recurrent miscarriages, especially if we have subclinical hypothyroidism and TBO positive. While other studies and meta-analysis and trials showed there is no benefit. Treatment regarding the cognitive development, levothyroxine during a pregnancy, a lot of studies showed there is no improvement in the cognitive function, and this indicates the early development of the neurons and the need for thyroid hormone, because all the study, usually the start of the thyroxine during the first trimester, and I think in this period the brain is already started to develop, and the deficiency affected the brain already. Now, the positive antibody usually increase the risk of subclinical hypothyroidism, because the mother will have the autoimmune condition, and this will lead to subclinical hypothyroidism. It is associated with the increased risk of recurrent abortions and increased risk of also premature birth. And the cognitive outcomes, there is no clear correlation between these, only positive antibodies with normal TSH. Now, if we have to treat the positive antibody, we have like this study showed there is 3 categories. One category, they have only miscarriage and the premature delivery. Group B, they have TBO positive untreated and TBO negative in the third group, and we can see that there is benefit with the treatment. But in the tablet study, it is randomized controlled trial, was associated with levothyroxine was initiated pre-conception, and the outcome was to see the live bears, and it showed there is no change in the live bears. Even there is no change in the live bears associated with TSH higher than 2.5. To summarize this, who should be treated? If the TSH is 4, normal or low free T4, whatever the positive or negative TBO status. No consensus if the TSH is 2.5 to 4 and the positive TBO and the prior miscarriages, and don't treat usually if we have a negative TBO with the TSH between 2.5 to 4, and if we have also isolated hypothyroxanemia. And I think within this year, the ATA will release the newest guidelines. Maybe it will be clearer regarding the recommendations in pregnancy. Maybe in August will be released, hopefully. So the take-home message is thyroid is tightly regulated during pregnancy to meet the requirements for developing fetus. Both hypothyroidism and thionidides have adverse pregnancy outcomes that needs balancing the risk and the benefits. Subclinical hypothyroidism is associated with negative pregnancy outcomes, but controversial results with thyroxine treatment. And thank you very much.
Thank you very much, Dr. Mohammed. It's excellent talk. The floor is open for discussion, questions. Any questions? Yeah.
Thank you. It was lovely. I just wonder about the technique you use for testing TSH and antibody. What is the technique? Is it normal ELISA or what?
Well, it depends on the lab. It should be checked with the lab in the facility you are working. Sometimes either it is ELISA or sandwich. I'm not very sure about the mechanism they are using and this.
Because that's affinity, you know, how affinity of the test is important.
Yeah, because usually if in any endocrine disorder, usually if we have any doubt, if any test, we have to rule out before believing the lab result, we have to believe the patient and the symptoms, not to treat the result itself. So if we are in doubt, we have to use, like, to repeat the test or to use other methods, or to use, especially if we have confounding effect. But if we have reliable test results, it shouldn't be a problem for us.
Yeah, that's
yes.
what I was. Okay, thank you.
Any other questions? Dr. Ahmed, now from your practice, what's the most pregnant lady in the Middle East, shall we say, or differ probably from the Western? Okay, do they come without definitive treatment like thyroidectomy or radioiodine? I mean, that will be better, of
yes.
course. Huh?
Yeah. It depends, because sometimes we are facing this problem, to be honest with you. We are stressing the lady at the first question for any lady with childbearing age. I'm asking her if she's taking contraception or if she has any plans during pregnancy, because from the initial visit, I'm trying to tailor the treatment for her if she's planning to pregnancy, to give her definitive treatment before she's going for a pregnancy. But unfortunately, still we are facing problems that they are coming pregnant while she's on carbimazole and these things. One experience a few days before coming to Bahrain, the lady was like maybe 15 minutes, and at the end she said, I'm pregnant. She didn't tell me in the beginning. So although I was asking her, are you pregnant? Are you planning to pregnancy? Whatever. Then at the end of the clinic, she said, when should I do? Because I'm pregnant. So sometimes it's difficult to, but I'm trying to, in the initial visit, to ask them, make sure if you are getting pregnant or you are planning to get pregnant, we need to give you the definitive treatment for better outcomes. But still, we are facing this problem.
Yeah, and that causes more problem, and
yeah.
you need to.
Yeah.
Yeah. I mean, now we know that all of this pregnancy and the disease of thyroid is an autoimmune.
Yeah.
Yeah. Now, we could see in daily life the autoimmunity from food, from other causes, from the environment. The autoimmunity is increasing.
Yeah.
Do you suggest to advise the ladies who's planning to be pregnant, and that usually we could not, because the pregnancy is like this. Do we could advise them that certain autoimmunity factor which increased should be avoided?
And usually, we are advising them for healthy lifestyle, healthy diet. The screening is not like if they have any thyroid problem in the family. Even that to measure the anti-TBO is not well established, and it will not change our management or the. But usually there is no certain medication. We cannot even give them like steroids or to IVIG or plasmapheresis. And even the ATA didn't advise against this practice.
Yes, thank you very much. It's
Thank
an
you.
excellent talk.
Thank you very much.
And we appreciate it.